Thank you for joining today's presentation. My name is Jackson Lau, and I'm the Senior Manager of Professional Relations at Euclid Vision Corporation. I'm also a practicing optometrist near San Francisco, and I continue to teach fourth-year optometry students who rotate through our clinic. And tonight, I'm joined by Christy Yee, our Euclid's amazing practice implementation and management specialist. She has many years of experience not only fitting lenses, but building successful specialty contact lens practices. And we'll spend the second portion of our discussion today sharing pearls on how to successfully implement myopia management into your practice. Before I begin, I want to thank the GelFlex team for inviting us to speak to you about this topic that is very important for Christy and myself. We live and breathe myopia, and we're happy to share our experiences. If there are any questions, please feel free to ask them through the Q&A box. We'll begin by discussing the benefits of myopia management using Euclid Ortho-K. Euclid is one of the most trusted Ortho-K brands for myopia in both clinical research and practice globally. I'll share some important tips on patient selection and troubleshooting strategies. And then Christy will dive into the important topic of implementation. For those who are not familiar with Euclid, our company is over 25 years old with a sole focus on myopia. Our consultation team and customer service are our strengths, and we optimize our lenses to be able to manage a wide range of corneal shapes and parameters. Our rapidly growing R&D team is constantly working on new designs and materials so that we can provide them to practitioners globally. I want to begin by asking the question, why are we worried about myopia? As we now know, there are significant public health ramifications from the growing prevalence of myopia, as it's expected to become one of the leading causes of permanent blindness in the world. And within 30 years, half of the world's population will become myopic, and 10% of those will become high myopes. As we can see with these alarming statistics, high myopia significantly increases the risk of more serious eye diseases compared to ametropes. A 6-diopter myope is almost 850 times more likely to develop myopic macular degeneration, over 12 times more likely to develop retinal detachments, and almost 3 times more likely to develop open-angle glaucoma. Simply reducing the rates of myopic progression can have a significant positive impact on your patients. Euclid's design philosophy is based on the concept of simple fitting, but complex designs. The simple fitting means that with just 3 parameters, Ks, your Rx, and horizontal visible iris diameter, we'll be able to design a lens that will be successful 87% of the time on the first try. So for novice or beginning fitters, this will allow you to have a great fitting lens without a significant input. But the complex design aspect of Euclid allows you to be much more proficient as you become a more seasoned practitioner. It allows you to make almost any adjustment that you'd like to fit your patient's needs, whether it's diameter, optic zone sizes, reverse curve, alignment adjustments, so that you can make sure you provide a lens that fits your patient's needs with a high level of precision. Euclid's proud to be one of the most trusted brands worldwide for Ortho-K research. There are over 100 peer-reviewed publications worldwide using Euclid lenses, and around 50 of those publications are specifically studying the effects of slowing eye growth and axial elongation. Here's one such study in the US, which was a 3-year retrospective review. There were multiple sites with independent optometrists who chose to use Euclid lenses 84% of the time. What they found was almost 70 to 80% of the children experienced minimal refractive error and axial elongation over those 3 years, and this was defined as less than or equal to a quarter diopter or 0.1 millimeter per year. In addition, the cumulative absolute reduction in axial elongation, also known as the CARE value, was around 0.32 millimeters over that 3-year period, which is a great result that's consistent with other prospective studies. Euclid Max offers all the material properties you would want in an overnight Ortho-K design, and we're very excited to share that with you. You'll get the same 87% first fit success. It offers great wettability without the need for any additional coatings or plasma treatment. And at 180 DK, it's one of the highest DK materials approved for overnight Ortho-K wear, and it's optimized to potentially resist warpage, scratches, and chips. The recent perspectives from this multi-center, multi-ECP analysis of Euclid Max found very high satisfaction rates. Almost all the ECPs experienced excellent first fit success and wettability using Euclid Max, and they felt it was better than or equal to other Ortho-K products and materials. And I want to share how you can maximize your Ortho-K success with the proper patient selection and provide some additional troubleshooting strategies. Before we get into the nitty-gritty on the design, I want to share some important details on patient selection and using our topographers to its greatest capabilities. I'll focus the discussion mainly on the MedMont topographer, but many of these features can be found in other topographers as well. Just like when analyzing, let's say, visual fields for glaucoma, it's important to not just look at the qualitative pictures, but I want to make sure that we're looking at a deeper assessment of the quantitative values that can guide you to be more effective in selecting your patients. In particular, I want to start this focus on making sure that you're matching your corneal cylinder with your spectacle cylinder. Now, you may recall from your early GP courses that you generally want to have a close match around maybe about a diopter between your refractive and your corneal cylinder. If you have greater than the mismatch of 1 diopter, you may lead to the patient experiencing a lot of unwanted residual cylinder. So let's take a deeper look into that. I want to recall that the total refractive astigmatism in any person is the sum of their corneal plus their lenticular astigmatism. And in this example, let's say you chose to start Ortho-K on a patient that has no refractive cylinder, but they have 2 diopters of corneal cylinder with the rule. What that means is that they'll have internally about 2 diopters of against the rule lenticular astigmatism. What happens is if you do any type of Ortho-K, there tends to be about a half reduction in their corneal cylinder. There's a sphericalization effect that takes place with any Ortho-K. But what that means is you will be likely inducing some amount of that internal lenticular astigmatism. And if you've had any patients that have started with no cylinder and suddenly you're adding about a diopter of against the rule cylinder, you may find yourself with an unhappy patient. So that's why it's so important to make sure that you're properly selecting the patient before starting any Ortho-K therapies. Next, I want to talk about corneal eccentricity, which is particularly important for designing Ortho-K lenses. As we all may be familiar, Ortho-K lenses typically land at that mid-peripheral or 8mm cord. And ultimately, the corneal eccentricity helps you determine the type of alignment curves you may want to use. So average eccentricity is around 0.5. And if a person has higher eccentricity values, that means there's a greater rate of corneal flattening from the center to the periphery. And in that situation with the higher E values, you may need to design the Ortho-K lenses with flatter alignment curves. Conversely, if you have a cornea with lower E values, let's say at this 0.3, that means that there's a lower rate of flattening, and therefore you may need steeper alignment curves in that mid-peripheral peripheral region. So this is important to sort of predetermine before you start any kind of Ortho-K treatment or therapy, to look at these kind of values carefully before designing your lenses. Some topographers will provide indices such as the IS index or these SAI, SRI, surface asymmetry or surface regularity indices. And I like to look at these more as a double checking just to make sure that we have proper scans and good reliability. If you have an IS index that approaches closer to 1, you may be dealing with a cornea that has a lot of asymmetry between the upper and bottom half of the cornea. And perhaps you may need to look more closely at things like corneal ectasia before proceeding. The SAI, the SRI, I liken them to reliability indices. And so if you find that they're flagged as yellow or red, you may be dealing with, first of all, a corneal issue, or more likely you may be dealing with a tearfilm issue, in which case you don't have a good scan to get the proper data for your Ortho-K design. So I always like to remove the color map and look at the Myers very closely to make sure that you don't have any signs of ring jam, that you have pretty parallel Myers. But if you were to see those indices flagged as abnormal, or you see signs of ring jam, then you may want to repeat those scans after instilling some artificial tears before proceeding. The last most important thing that I think you need to take into account before designing your ortho-K lens involves looking at sag differential at that peripheral cornea. And again, that's typically at that 8mm chord. Typically, these are measured based off of a best fit reference sphere. If you have corneal elevation that's below that, you will see that you'll have negative values. And if you have elevation points that are above that point, you'll have positive values. So in this scenario, you may have negative values in this width the rule cornea and positive values in this horizontal meridian. And if that difference between those two meridians is greater than about 25 or 30 microns, that often suggests that you will need a toric periphery design for your ortho-K effect to work properly. Oftentimes with our modern instrumentation, they can do this analysis automatically for you if you find the analysis tools. Again, this is the MedMod, but here's the Pentacam, which can also automatically calculate these differences for you. And let's say you were to want to have a gut check. This research came out of the University of Houston by Dr. Tomiyama, and they found that there was a strong correlation between corneal toricity, which is typically measured in the central Ks. There was a correlation between your corneal toricity and your peripheral elevation difference. So right around the 1 diopter mark, each diopter of corneal toricity can indicate that you're at that 25 micron elevation difference in the periphery. So that's when you may need to consider that toric peripheral ortho-K design. Let's move on to some of the fluorescein pattern analysis, because I think this is critical before you start any kind of venturing into myopia management with ortho-K. When I start to assess any type of ortho-K design, I usually start by looking at centration. Nowadays, the next step I'm looking at is, do we have the proper diameter? And this is critical because having the proper diameter relative to the corneal size or the HVID is one of the most critical factors to having a proper fit. So these days, many manufacturers are leading practitioners towards larger designs. Some say about 95% of that HVID is appropriate. So we'll talk a little bit more about diameter next. But moving to the rest of the fluorescein pattern, you have your central base curve area, that treatment zone area. You have this mid-peripheral steepening or this reverse curve or return curve ring. And then you have your alignment curves. And then lastly, you have your outermost peripheral curves. So if we were to look back at diameter, again, this is one of the most critical factors when determining your ortho-K design. If we look here, we designed lenses of different parameter ranges, and that's one of the benefits of using Euclid, is that you have this flexibility. You're not just obligated to just use one size, like a small, medium, or large. You can have this precision to design the lens to your liking. But the beauty of this is that we can see the dramatic differences between a smaller diameter versus a larger diameter. On the left here, we can see that this smaller diameter has quite a bit of movement after the lens blink. Contrast that with this, increasing larger diameter as we go to the right. And if we go all the way to the far right, we can see that this lens barely even moves. It's acting like almost like a corneal scleral lens. And so somewhere in this middle range may be appropriate, where it's not overly large crossing the limbal stem cells, but not too small where you have too much movement, because that can lead to things like decentration. So that's one of the most important factors in terms of designing your ortho-Ks, just making sure that the diameter is appropriate. Because if not, you're going to deal with improper centration, which can lead to poor visual outcomes. Another hot topic within the myopia management space, particularly with ortho-K, is the topic of optic zone sizes, which in turn translates to treatment zone sizes. So similar to diameter, it's most obvious if we were to look at this extreme, this here picture on the left, with the smallest optic zone size we can create with the Euclid lenses at 5.0 millimeters, and contrast this with our largest optic zone size at 6.6 millimeters. And we can see that dramatic difference in the size of that green ring. What that does, though, is that it induces a certain amount of treatment zone size onto the cornea. And if you follow any of the research, and you'll see that potentially having these smaller zone sizes, treatment zone sizes, can potentially slow down the axial elongation even further compared to these larger optic zone sizes. So keep that in mind when you have your patients, typically for myopia management, and if you're attempting to slow their eye growth, you may want to steer towards these lower optic zone sizes. And conversely, if you're treating adults or children who are past myopic progression age, who are very at low risk for progression, you may want to do larger optic zone sizes so that you can minimize their aberrations and glare. But that's the beauty of using something like the Euclid design. It allows you that flexibility to choose the parameter to your liking. This research came out recently within the past couple of years, and their 2-year results, I think, are coming out soon, if not this year. And they found exactly what we just discussed, that using these smaller optic zone sizes can, in fact, potentially slow down eye growth even further compared to the larger optic zone sizes. Moving on to some other nuances with ortho-K fitting. On the left here, we see actually all these lenses will have excessive lens sagittal depth. But starting on this left picture, we no longer see that perfectly defined bullseye pattern. Instead, we see this light little feathery clearance near that center of the optic zone. If we were to slightly increase the sagittal depth of the lens further, you'll see that that definition is slowly going away even more. And again, even further, if we have too much sagittal depth, you'll start to induce more insertion bubbles or air bubbles once the patient puts on the lens. And in this rightmost extreme example, you'll see that it's actually almost acting like a suctioned on scleral lens, and fluorescein is not even getting into the eye until the practitioner is actually inducing and nudging some fluid underneath the lens, because you have such a tight seal with this excessive sagittal depth to the lens. In these scenarios, you often lead to troubleshooting issues such as central islands. It may lead to inferiorly decentered lenses. You may see some double ring patterns that corresponds to the insertion bubble. And ultimately, you may even get things like lens binding. So here's an example of lens binding. I often tell my students, or the first time I show them this video, is that tell them that there's actually no lens on the eye. This is after one night of ortho-K wear. And so in this example, we can see the areas where there was the lenses was too much lens sagittal depth, and it was almost digging in or imprinting onto the cornea, and so much so that it suctioned onto the eye and even caused some central staining. So we obviously don't want to let this linger, and we want to make some adjustments to our lens design before we can lead to greater risk of ulceration if we were to let this continue to fester. The opposite scenario is if you have insufficient lens sagittal depth, and this is where instead of that dark alignment curve, you're going to see a lot of fluorescein getting underneath the lens, and you're not going to get that proper seal for the ortho-K effect to work properly. This will often lead to superiorly decentered lenses or smiley face pattern. In this right example, this is a lens that has insufficient sagittal depth in just one meridian. So if we were to look at the topography pre-treatment, they have pretty strong, almost limbus to limbus with the rule of astigmatism. And if you don't have the proper sagittal depth to the lens to the cornea, you'll see that you're going to have this sort of fluorescein leakage or improper seal in this vertical meridian. So these are some examples where you don't have sufficient sagittal depth to your lens, and that can lead to improper treatment. It can lead to decentration. It can also lead to a common scenario, which is you can have mechanical rubbing of that back surface of the lens on the eye, and that can lead to corneal staining, SPK. It can even lead to bigger patches of almost looking like an abrasion. So we don't really want to have that happen as well either. And so this is something to be cautious of, particularly when you're dealing with patients with higher levels of myopia. One of the last images I want to share with you before we move on to some of Christie's implementation topics is the idea of, if you ever recall Munderland's formula from refractive surgery, there's different corneal shape changes that you can have based on the amount of desired refractive changes. So in these three examples, they all have it's the same eye, but we're attempting different levels of refractive or myopic treatment. And typically, if you have lower levels of treatment, you may not see that well-defined bullseye pattern compared to if you have more moderate to higher levels of myopic treatment. So that's just something to keep in mind, especially if you're new to ortho-K fitting and just beginning. Even if you don't see that perfect bullseye pattern on a lower myope, you may still be on the right track, okay? So I want to end with a couple last review articles. This is just the reminder that if you are trying to jump in with the more complicated cases with the higher levels of myopia, oftentimes there's reports and research that suggests you'll get higher levels of corneal staining. So just be cautious before you manage those type of patients. Make sure you're having extra follow-up care and monitoring those patients carefully and closely. A couple of troubleshooting general tips. I always like to remind practitioners to always evaluate the cornea. Oftentimes you'll be able to see things on the cornea before you will notice things, before the patient will notice anything. So it's important to evaluate the cornea. Typical overfractions are between that plano to a little bit of plus range. If you have abnormal overfractions, that may mean that you have a refractive issue. And so you'll have to either change the base curve steeper or flatter, depending on the type of refractive issue that you're dealing with. And if there are any fit issues, you're not typically changing the base curve like regular corneal GPs. Fit issues, you're typically changing things like the diameter, reverse curves, or alignment curves. So just keep that in mind. There's a slight difference between ortho-K troubleshooting and regular daytime corneal GP fitting. And lastly, patients often can have more than one problem, so you'll often need to tease out one at a time before you solve their issues overall. So with that, I wanted to hand this over to my colleague, Christy Yee. She's going to talk about the fun stuff. Now that I've shared a little bit about the basics of why we're doing this, why is myopia management important, how to troubleshoot the basics of ortho-K, she's going to go into practice implementation, all the secrets that she can share so that you can be successful in your practice.
Before we get started, I would like to thank Dr. Lau for inviting me to participate in this evening's program. And I'd also like to thank GelFlex for allowing me to be a part of this. As Jackson mentioned, I am excuse me, the Practice Management and Implementation Specialist for Euclid Vision Corporation. Practice management is a very large topic, and we're only going to be able to scratch the surface of topics for implementing myopia management into your practice tonight. So I do want to make certain that everybody that's watching this is aware that between Euclid and GelFlex, we are going to make my one-on-one services available for you. So no matter what type of roadblock or hurdle you may be experiencing in your practice, if you need implementation services, Euclid is here to help you. So tonight, to get started, I've chosen 4 little nuggets that I think are really important when you're considering implementing myopia management into your practice. The first little nugget is really just identifying your why. Start to think about the reasons why you want to bring myopia management into your practice. Is it because you want to provide the best possible care for your patients? Are you looking to become more of a specialty practice where you're doing more high dollar services and evaluations? For some, it's like a freedom from an insurance policy. So there's just a lot of different motivating factors as to why optometry chooses to go into myopia management. And I think financials is probably one of the biggest key drivers, and it's a compelling one. If we do just kind of like a traditional little pencil sell, and granted this is US dollars, but if you assign a dollar value of your typical myopia management patient of like $2,000, even if you were to do 3 patients a month, and pretty much anybody who's doing routine eye evaluations in their practice has 3 candidates coming into their practice every month that would be eligible for myopia management services. So, that's a very reasonable number. This is not you doing anything extra. You're not doing any marketing. You're just capturing those patients as they are in your office. You'd have put an additional $6,000 onto the bottom line in contact lens sales at the end of every month. Big picture, we're looking at that adds up to $72,000. Now, like what could you do with $72,000? There's a lot of potential there. That is for a lot of you another salary for another staff member. That's a new piece of equipment, maybe that new Pentacam that you've been drooling over. That might be an amazing, 2 weeks off of work and a vacation where you're going to invite me. So there's a lot of potential that you could do with very minimal effort in terms of specialty lens patients in your practice. Another way to look at this is just working smarter and not harder. So if you look at that $72,000 and you divide it by the average cost of a 2-week disposable contact lens, and you'd have to see almost 300 patients or 36 myopia management patients. So it does open up your practice for other opportunities as well. So kind of keep that in mind. But one of the biggest things that I can't stress enough is for whatever your reason and for whatever your why, just make certain there's passion behind it. I have unfortunately consulted with a doctor who he has all the tools, he has all the knowledge to fit the lenses. He doesn't like children. He doesn't enjoy working with children, and he's just not had a great success in terms of implementing this in his practice. And I've even gone so far as to sit in on a couple consultations with him. And after the second one, it was just abundantly clear that he does not enjoy this. It is not his, it's not his forte. And so unfortunately, there's just zero passion there. And it just comes through with all of the interactions he has with the parents. And so our conversation was, if you're not bought into it, you're going to have a really hard time getting parents to buy into this program as well. So the key message here is just whatever you do, make certain that you have a passion for this. The other little nugget in terms of identifying your why is also planning to be successful. Now, this means that you're going to sit down and you're going to really outline what your plan of action is going to be. What are your goals? How you're going to achieve those goals? Just identify a timeline and just really, sit down and think about your implementation and what tools you're going to need. Try to anticipate some of those roadblocks and some of those barriers. And if there's something that anybody here at Euclid can do to help you overcome some of those barriers, we're here for you. We have a lot of implementation tools at your disposal. So please let us know. I also, at the end of the webinar, I'm going to make it's called a SMART goal planning sheet that's geared more towards the implementation of myopia management. We're going to make that available to everybody at the end of the webinar that you can just kind of keep as a living document. I recommend filling it out. And then, every month or two, go back, look at your document. Are you reaching those goals that you set for yourself, and try to hold yourself accountable? The other thing too that I think is really important is incorporating your team. This can't be a one-person show. This definitely needs to be a full team effort. So make certain you're talking about it with your staff, making certain that they're working towards the same goals you are. The next little nugget that I want to cover, and I think this one is probably one of the most important ones, is setting a consultation for myopia management specifically. So what I mean is, I don't want you introducing the concepts of myopia management and trying to essentially close a sale at the end of an eye exam. It's too much, it's too soon. You're identifying a condition that most parents are not aware of, and then you're identifying a solution that they're also equally unaware of. And then you top it off with, it's not covered by insurance and it's going to have this significant out-of-pocket fee. And unfortunately, a lot of parents are just like, I need to talk with my spouse and we'll call you back. And the reality is they're never calling you back. They can't make that decision on the spot. And the next time you're going to see those patients is unfortunately at their next routine eye exam a year from now. And in all likelihood, what's happened is the child has progressed. So in order to increase your capture rate, one of the tools that I strongly recommend is using a myopia management consultation. This ideally happens 1 to 2 weeks after your routine eye exam. And there's some psychology behind that, where we want to allow those parents enough time to really understand what you're telling them. So introduce the concepts at the end of the exam. So the conversation in office goes something to the effect of, So we've done Johnny's eye exam, and the good news is that his retina is very healthy. Everything in the back of the eye looks great. One of the concerns we have is that the last 2 years, Johnny's prescription has really changed, and it's really outpacing his age. And it's to a point where I think we really need to look at an intervention. If we allow this to continue, he could have a lifelong trouble with vision, including permanent vision loss. And so it's very important that we talk about a myopia management strategy. So what I'd like to have you guys do is come back. We're going to schedule you guys for 2 weeks. We'll do some special testing at the follow-up, and then together the three of us will sit down and discuss what the best option for correction going forward is going to be for your son. And so at that point, what I would do is walk them out to the receptionist and schedule them for that follow-up in the 1 to 2 week period. I don't let them leave the office until that is on the book. But that, typically allows them just enough time to absorb what you said and understand the seriousness of it. I didn't really introduce we didn't have big conversations about the modalities. I didn't talk to them about really expensive contacts or anything like that. I'm just really identifying that there is a medical need that we need to address with their child. And so the takeaway there is that you want to keep the focus on the eye care versus the eye wear. During the consultation, you guys can discuss the different modalities that are available and why you think that one is going to be the best to meet their child's needs. So one of the next things that I hear too is that I ask everybody about it. I'm introducing these concepts and nobody chooses it. It's too expensive. And I just want to push back on that a little bit and make certain that everybody is aware that parents inherently want to do what's in the best interest of their child. So if for some reason you're getting this objection a lot, I would recommend that you reevaluate your process. If your capture rate isn't in that 75% range or higher, you're probably not adequately explaining the value of what you're trying to bring to that parent. They're not understanding what you're trying to get their child involved in. Because even like when you look at like orthodontics, parents are willing to spend thousands and thousands of dollars for essentially straight teeth. Now, I have a friend who's an orthodontist who will attest to the value of a well-aligned jaw and teeth, but ultimately the driving force for parents is aesthetics. This is a child's vision. So if they understand that, this could save their child's vision, they're going to be more likely to go forward with actually establishing a treatment plan. Now, along with your capture rates, there are some things that I feel like every doctor should be aware of when they're introducing the concepts of myopia management. And that's really how we introduce these different modalities. And so if you walk into a room and say, well, so the good news is we have hard lenses and we have soft lenses that your child could wear. You've just introduced a whole bunch of different biases into that parent's brain, and you haven't had a chance to say anything about the contact lenses at all. Because when I say the word hard contact lens, what is the first thing that comes to mind? Probably uncomfortable, difficult. I didn't know they still made those. My grandma wore that. It's really old technology. So there's all of these barriers that a parent has instantly put up in their mind the minute you said hard contact lens. And then when you say things like soft contact lenses, parents are a little more familiar with that. This is their generation's primary mode of contact lens correction. Unfortunately, they don't really see the value of a soft contact lens, and it's certainly not a value that's worth $2,000. So again, make certain that we're keeping that focus more on the eye care versus the eye wear. These contact lenses are simply the mode that you're using to address their child's progressive myopia. And I encourage you that when you're introducing these to use terms like a night lens or a night retainer and a daytime lens, or maybe even a day retainer. Just something so that when they're coming to the table, they're just a little more open-minded to the correction that you're going to provide their child. So they don't have all of those biases that you now will have to overcome. You're introducing that something that's already kind of foreign. So just make certain that we're taking as many of those roadblocks out as possible. And same thing for when parents ask you specifically with orthokeratology, is this uncomfortable? Does this hurt? Parents, as they start to understand that this is more of a rigid material, they start to wonder, well, what is this going to feel like for my child? And I've heard some train wrecks where doctors will say, well, yeah, I mean, it's going to feel like you have something in your eye, and, your child's going to probably, blink a lot and their eye is going to water, and, they keep going. And then all of a sudden they're like, but don't worry, it gets better. And it's not terribly reassuring. That's not an experience that I would want to personally go through. It's not something that, when explained that way, I wouldn't want my child to have to go through that. And I certainly wouldn't want to pay somebody for that experience. So we want to make certain that we're overwhelmingly positive and really reinforcing the value of the therapy. So when that conversation comes up in office, how I address that is the conversation is like, you know what, mom, that's a really great question. I want to reassure you, number one, these lenses do not hurt. There will be some lens awareness for the first couple of weeks, and that's totally normal. I understand that you're a little apprehensive because this is kind of a new concept for you guys, but I want to reassure you that before you leave the office with the lenses, Johnny's going to have the opportunity to try them on in a very safe space here. We're going to teach you guys both how to insert and remove them, and everybody will be really comfortable with everything before you guys go home. And then that next morning, you're going to come back and we're going to talk about everything that went right, and any areas that you still need to work on the very next morning. So I just, again, try to make certain everybody is just really like reassured and feeling very comfortable about everything. And when we talk about lens comfort and lens awareness, we're talking about it in a very positive way. During the actual insertion and removal and dispense appointment, that's typically where I will put the lens in the child's eye for the first time. And with that, typically I will use a little bit of proparacaine. Now, I know some optometrists choose not to. For me, this was one of those things where I would rather have the child be apprehensive and a little afraid of my eye drops versus the contact lens. I'd rather have them have a positive experience with the lens initially. So I do use the drop. I tell the child ahead of time, it's a little spicy. I apologize. It's spicy, but it's only spicy for a second. I have the tissue handy. And then as soon as we get those lenses in, I will check the lens movement and centration. I quickly check the visual acuity. And then typically what we'll do is after that is I will just observe the child. And within a minute or two, you can actually start to see that the child is blinking more. They're becoming a little more aware of the lens on their eye. And so that's when I'll say to the child, you know, Johnny, I can see that you're a little more aware of that lens. Can you tell me what it feels like? And they're like, it's just a little blinky, or it's just making me blink a little bit. And I'll say, but it doesn't hurt, does it? And they're like, no, it's just making me blink. And I'm like, yep, that's a totally normal feeling for these lenses at first. Can you do me a favor? Can you close your eyes and look down? And as soon as they close their eyes and they look down, that sensation goes away almost entirely. The sensation of the lens on the eye is being driven by that upper eyelid. And so as soon as they close their eyes, the lens wearing experience improves tremendously. And I'm like, that feels better, right? And they're like, yeah, it feels better. And I'm like, this is exactly what it's going to be like tonight when you put the lenses in at home for the first time. So when you put them in, it's going to be a little blinky, but as soon as you hop into bed and you close your eyes, that sensation is going to feel just the same way it does now with your eyes closed. You can do this, right? And so I have them verbalize that, yeah, this feels better. I can do this, you know? And so now I've given them the tools necessary where they're feeling a little apprehensive. Now they have those tools necessary to deal with that foreign body sensation. They know that as soon as they hop into bed and close their eyes, it's all going to feel better. And then I just reassure them even further. And every day you do this, it's going to get a little easier and it's going to feel a little bit better. By the time they've done insertion and removal training, that eye is 100% awake. That child has had a very positive experience and a very realistic experience of what it's going to be like when they put that lens in a few hours later at home. So again, just make certain that you're overwhelmingly positive and reassuring the parents that, you know, this does not hurt. There is no pain associated with lens wear, that there is some lens awareness. Just like braces, there's going to be some awareness for a couple of days, but it does get better the longer you wear the lenses. And then my last little nugget before we run out of time is just making certain that you're maximizing your efficiency by utilizing your team. I think a lot of optometrists sometimes forget the value that a well-trained associate can bring in terms of increasing your efficiency in the actual exam room. So the list that you're looking at is the list of a specialty contact lens technician duties here in my home state of Minnesota. And so as you can see, we participate in a lot of the actual process of getting the patients fit for contact lenses. Now, every provider is going to have a little bit of different comfort levels with their staff participating in this, but wherever possible, I really strongly recommend that you take that technician under your wing, teach them how to do one thing. Maybe that's check angles for you. And once they're successfully identifying angles, go to the next one and just keep giving them little duties in office, because not only is that going to increase your efficiency and your ability to see more patients, but it's also going to give them a greater sense of job satisfaction. You know, it's a very powerful thing when your technicians are able to help you out in the office. You've given them a career, not just a job. Your turnover is likely a lot less, and just everybody works in the office far more cohesively, and it'll allow you to stay focused on more of that exam revenue generation versus some of the more mundane stuff like answering patient parent questions, especially when it relates to like lens handling, lens care, and things like that. If you've got a well-trained staff member that can do a little bit of triage and help you out with some of that, it'll keep you focused on more of the patients that are actually in your office for that day. The other things too to consider in your dispensaries when you have glasses, just make certain that your opticians know their role in a specialty contact lens practice, because opticians can be a little disenfranchised when it relates to specialty contact lenses, because they're like, no, I'm not selling them. It's not really, it's not really my thing. Especially if these opticians are more commission or like spiff based in their compensations, just make certain that any programs that you set up also benefits them as it relates to myopia management, so that the way they're not penalized. And then they also need just to understand like how to sell glasses to your myopia management patients. So obviously, like the daytime contact lens wearers are going to still need correction every single night from when they take those lenses out. But it gets a little more gray area for some of our orthokeratology patients. And a lot of opticians are like, well, they're wearing the Ortho-K lenses, they probably don't need glasses. But I got to tell you, kids are dermy. At some point in their orthokeratology treatment plan over the years, they're going to develop some sort of pink eye, where you'll at some point in time recommend that they wash out of their lenses for a couple of weeks, let their eyes rest. That might involve some antibiotics or something like that. And they're going to need a backup pair of glasses to fall back on. Same with ultraviolet protection. It's pretty standard to put kids in polycarbonate lens materials, which is inherently UV blocking. If you're using orthokeratology lenses, and many of the soft daily disposables, we're losing that ultraviolet protection. So just making certain that the opticians know how to sell ultraviolet protection, either in the form of prescription or non-prescription sunwear, is very important. So that's all the time we have for this evening. Again, we've only scratched the surface. So if you have any questions, we're going to be on. You can put those questions in the chat box. We're gonna be on for a little while to answer those. And for anything that's more in depth, again, I'm happy to set up a time with you guys one-on-one to discuss like global pricing policies and how to best address some of that cost with parents. Or if you even just want to like troubleshoot how to introduce the concepts, I'm here for you. So it's been a pleasure. Thank you so much for having me. We'll talk to you in the chat.
Good evening, everybody. Feel free to put any of your questions in the chat or in the Q&A box. My name is David Bland. I'm head of sales for Euclid, and I'm joined by Christy and Dr. Jackson Lau and David Toner from GelFlex. So we're going to go through a few of the questions. We've got a couple now. Jackson and Christy, here's one for you. What's the most common pushback that you get from the parents when you're presenting myopia management, and how do you handle it?
Do you want to take that, Christy?
Sure. I think probably one of the most common pushbacks that we used to get a lot of is probably related to the cost of an overall myopia management program. I don't think it really matters the modality. The cost is usually just something that's maybe a little more unexpected, especially if this is like a first visit. Their parents are typically anticipating coming in and maybe getting a new pair of glasses for their child. And so when we start, deviating from that expectation, I think there's oftentimes a little bit of pushback.
Great. Here's another one. Do you need a topographer to fit the lenses, and if so, which one would you recommend?
I can try to take that question, David. So in all sort of most modern designs and companies these days, we do highly recommend usage of topographers for the management of the treatment, as far as watching let's say the size of the treatment, the location of the treatment. Certainly to really get started with Euclid's 3-factor fitting, topographer usage is not exactly 100% necessary, but for the ongoing management of the patient, we would highly recommend the usage of topographers. And typically we don't have a strong preference for which brands of topographers, but that being said, some of the most popular ones tend to be maybe the Medmont, whether it's the Meridia or the older versions. Oculus has their Kertograph, Atlas. There's a bunch of topographers out there that can basically do the job. So we're not too specific on which ones you need.
Yeah, and then I would, just to kind of to tag off of that a little bit, in terms of like the practice management, like Dr. Lau said in his presentation, go ahead and take your color maps off and really look at your placido rings and look for things like ring jam. Make certain you're having a really high quality image that you're sending to the lab, because that is what we ultimately use to manufacture your lenses. And so, the extra 5 minutes to take a better image will save you tons of chair time trying to troubleshoot a poor fitting lens.
Yeah, but good advice, Christy and Jackson. So how do you handle the situation? Here's another question, Jackson or Christy. How do you handle those situations where the parents, after you've fit a child, and maybe the visual acuity isn't 20/20 or as sharp as the parents expected? How do you deal with that?
That's a great question, David. So 20/20 or 6/6, it's not the number one goal. So the number one advice I actually try to give practitioners who are starting off with myopia management, whether it's ortho-K or any other modality, we should realize that a lot of what we're doing is going to induce aberrations and sometimes glare and halos, and therefore all modalities that we typically use these days provide less than optimal vision. So if we set the expectation at the onset of therapy or treatment, stating that, hey, your child is going to have a certain level of vision. If we can achieve something around that in the US 20/30 or 6/9 acuity level, ultimately that's going to be sufficient for their functional needs. And as long as we're slowing down their eye growth, and certainly we didn't get too much into the details of measuring axial lengths, but if you do have that capability or that instrumentation within your office, having that as the benchmark for the success of your myopia management would be really, really helpful, as opposed to the parents thinking about their uncorrected acuity, which can vary depending on the time of the day, depending on their dry eyes, how many hours they slept. So ultimately, try to steer the parents away from the uncorrected acuity as any measures of success, but instead looking at the myopic progression, whether it's through refractive changes or axial length changes.
Super. Here's another one too. When and how frequently do you order a toric design?
Sure, different practitioners have their own experiences. Christy, you can share yours, but on average, we're finding that if you were to just look at the population statistically, it may be about a third of patients who actually need a toric design based on their corneal shape or corneal elevation. We are seeing a trend, at least in the US, towards higher volumes of toric amounts. And this may stem from the fact that even smaller amounts of corneal toricity or elevation may benefit from using toric peripheral lenses, and this just helps with centration and fit. So ultimately, don't be shy. A lot of practitioners are maybe concerned with using torics if they haven't been used to it in the past, but we are finding a trend towards increasing amounts of toric usage, and it just may help if the patient needs it, if the cornea needs it, it may help for better fit and centration. Any thoughts on your end, Christy?
No, I would just say that I think my usage was probably greater than 50% toric. I feel like the vast majority, probably at least 65%, maybe even higher utilization in my office. I think some of that's probably population based. I know that when we're dealing with certain ethnicities, we see greater amounts of astigmatism, but just in general, as I became a more competent fitter, I started reaching for that toric lens more and more. So I think a lot of it is just practitioner like familiarity and comfort level with the fitting process.
Yeah, and Christy, I think too another element here, the consultants, the consultants at GelFlex, where you will order your lenses, can be a big help there. Graham and his team, I highly encourage to tap into their expertise, because they're very well trained in these, and they see multiple cases a week of the types of fits that maybe you might be seeing once a month. Yes. And so do tap into that expertise. If that's all the questions we have now. I don't know if there's any other questions. Feel free to fire them away through the Q&A box. I did want to remind everybody while we're waiting to see if any more questions come in, we have David Toner from GelFlex. If there's any questions related to GelFlex, who is our business partner in Australia, and they provide, as you probably know, excellent service, and they've got a great consulting staff. So you'll be ordering your Euclid lenses, Euclid Max lenses through GelFlex. If there's any questions specific to GelFlex, feel free to put those in the box as well. Well, it doesn't look like we're getting any more questions. So
we actually have another one in the webinar chat.
Okay.
It says, how long does it take for the lenses to arrive?
Oh, that'd be a question for me then. Generally, from the point of order, we look to try and get these lenses out between 3 and 5 days, but sometimes it'll go up to 7 days. That's the usual time frame.
And then there was one other one. Do most patients only need one lens or a series of lenses to achieve acceptable flattening?
That's a great question, John Parsons. And so statistically, based on some of the internal data analysis work that we've done, we found that your first lens is going to be successful 87% of the time. And so the idea that you may need a progressive set of lenses to achieve the flattening, that's more of a maybe decades old or multiple decades old theory based on when Ortho-K was first being developed, maybe by accident. And so practitioners before we understood some of the concepts of whether it's hydraulic fluid forces or just how orthokeratology works with some of the older designs, that's where you did have to do that progressive flattening. It was a little bit on the more barbaric side, and nowadays we are able to do the calculations much more accurately and precisely, so that your first lens is probably going to work 8 or 9 times out of 10. Certainly, if you do not follow the proper patient selection, if you're choosing very complicated eye shapes, lots of astigmatism, very high myopes, they will likely require some kind of modifications or pre-adjustment to really have your best chance of success. So there's a lot of factors, but generally, I think you can be pretty confident that your first lens is going to work really well if you have the proper patient selection.
Oh, here's some more questions coming in. Good. What's the usual replacement schedule for lenses? 1 year, 18 months?
You want to take that, Christy?
Sure. So I am like uber passionate about making certain that my patients replace their lenses every year. Even if they have no like demonstrated change, I'm still like uber passionate about them replacing those lenses every 12 months. And the reason why is that as soon as you start going beyond that, these lenses start to change shape just because of natural use and wearing and the cleaning process. And so at some point in time, they're going to come back to you and they've had a change in their vision and their visual acuity. And now you're like, well, shoot, is this a natural prescription change or is this a lens-induced change? And so now you have to troubleshoot that. And so you have got a couple options. You can wash your patient out and start over, or you can order the last known parameters and have them come back to see you in a couple of weeks and then make adjustments there if necessary. Either way, it's extra lenses, it's extra chair time. It's not good for you. It's not good for the patient. So I'm really passionate like about every 12 months you're coming back and you're getting that new lens.
Just to add to that great answer, Christy, please, if there's any possibility of setting that expectation at the onset of your Ortho-K management, that would be ideal, so that it's not a surprise to the parents, 12 months later that there's an expense. So basically, set it in writing, explain to them that this is an ongoing treatment, and not only is it for starting the first year, but every year we're going to have an annual replacement. This is to maintain good health, good vision, and minimize issues that, some of the things that Christy mentioned, that will lead you to much better and easier conversations down the line so that the parents have that expectation up front.
Yep. And then like one of the other things too is that, remember our ultimate goal here is for myopia management. So having those regular intervals, I think really helps reinforce the eye care aspects of this versus the eyewear aspects of it. We're concerned about their axial length progression. We're wanting to monitor that. So having those regular 3 to 6 month intervals of office visits, I think is really important.
Here's another question, which I can answer. Are Euclid lenses manufactured in the USA or Australia by Gelflex? Currently, they're manufactured in the USA. Our facility is in Sterling, Virginia, just outside of Washington, D.C., and we ship the lenses pretty much on a weekly basis to Gelflex. That's how the situation works currently.
I just add as well to that, David, I want to retract that last statement I made. I got a little bit confused. The lead time for lenses is generally between 2 to 3 weeks max. I said 3 to 5 days. I was kind of a little bit off there. So just reiterate, it's between 2 to 3 weeks.
Yeah, thanks, David. And here's another question, and we get asked this a lot. Which contact lens solutions do you prefer? That's a very common question.
Yeah, very common question. Ultimately, the safest answer is anything that's approved for GP wear or gastrointestinal lens wear. That being said, I find anecdotally, clinically, my success in having less complications and patients having irritated eyes tend to be sticking with preservative-free systems. So while we do realize that there's a worldwide sort of supply chain shipping, shortage issue with hydrogen peroxide type preservative-free systems, that does tend to be my preference. That being said, sometimes patients do still need some kind of cushioning or re-wetting solution prior to insertion. So again, my preference is still sticking with preservative-free systems like ClearCare. If there are difficulties, if it's available, I find that Unique pH is a very popular one as well for my ortho-K patients. And certainly the Boston, products are approved, at least in the US. So Boston Simplus, but they can cause some kind of sensitivities for some of my patients. So I do lean towards preservative-free.
Awesome. Great questions. Just waiting to see if any more come in before we wrap up. Well, it looks like that's probably the end of the questions. That's quite a list of questions. Great questions as well. So I wanted to just extend my sincere appreciation for each of you for attending and sitting through our webinar tonight. Thank you to Christy and Jackson for presenting, and David and the Gelflex team for their business partnership. If you have any information, or need any information, I'm sorry, it's listed in the chat box, or feel free to reach out to the folks at Gelflex, orders@gelflex.com. And don't forget to take advantage of Christy. Her services will be available in partnership with Gelflex if you would like a one-on-one consultation for implementation. So without any further ado, I guess we'll give everybody back the rest of their evening, and we can go back to bed here in the United States. You guys have a great day.